So today's video, as promised, is going to be in the eye. So the topic for today is congenital glaucoma. So congenital glaucoma is not a very common problem, but still it's a pretty serious problem. So the topic for today is congenital glaucoma. We divide it into true congenital glaucoma, or infantile glaucoma, or juvenile glaucoma. So the true congenital glaucoma is going to be the one which is present at birth. So at birth, if the person has glaucoma, it's called the true congenital glaucoma. Infantile glaucoma is somewhere around the infant age, around 1 year. So the average is between 3 months and 3 years. So if the child tends to develop glaucoma in this age group, it's called a congenital infantile glaucoma. And the third one is the juvenile glaucoma. Juvenile glaucoma meaning 3 years to 16 years is the cutoff value. But however, the famous books in ophthalmology tell that both the true congenital and infantile glaucomas are one and the same, and the age of presentation is approximately 3 to 4 months, and that the juvenile glaucoma is does not have this cutoff. It says the late congenital glaucoma is going to be between 4 to 10 years, and 10 to 35 years is called the juvenile glaucoma. So that's a contradictory topic, but I thought it must be highlighted. So yeah, that was congenital glaucoma in short. So let's take a very quick view onto the etiology of it. Etiology of congenital glaucoma. So etiology includes, it's either primary or it's secondary. It's due to inflammatory reaction, or it can be due to some sort of an injury, or it's either due to a syndrome or is due to a surgery. So it's going to be either one of them. Okay, and the pathogenesis behind it is going to be two things. So one is failure of the development or abnormal development of the trabecular meshwork. Okay, so the trabecular meshwork in the eye is called the TM, so the trabecular meshwork. So that's going to be formed in a very poor fashion. I'll tell you how. So there's this cornea and then the iris like this, and behind it is the lens. So this is approximate way how we draw the eye, like that's the easiest way to draw the eye. So this is normal, but what happens is that the development is going to be a bit problematic, where cornea like this is going to be in contact with the iris like this, and the lens is going to be somewhere like this. So like the iris has pushed forwards, and so that's how the eye develops. The eye will develop in such a way that the iris and the cornea are going to be formed approximately together, and that the iris is not going to be separated from the cornea. So what happens is that there's this angle, as we already know, this is antechamber and this is the angle of antechamber. So in case of glaucoma, the angle of antechamber is reduced, or it's a bit shortened. Okay, so that was the main issue under glaucoma. Okay, so that's the first pathogenesis. I'll tell you what happens after this. So because the angle of antechamber is going to be closed, the intraocular pressure is going to raise. Once IOP raises, then there's going to be a lot of changes, like there could be cupping of the lamina cribrosa, or there can also be stretch. Stretch occurs in both cornea and the sclera. Well, we'll see how this affects the clinical features of the baby. Okay, so before going into that, we'll see what syndromes are often associated with it. Neurofibromatosis syndrome or Sturge-Weber syndrome are most often associated with this. So that was about the first pathogenesis. The second main pathogenesis is going to be for juvenile glaucoma. So in case of a juvenile glaucoma, it's inherited as an autosomal dominant condition where there's a chromosomal problem, obviously, where in the long arm of the chromosome number 21. So this arm has the protein The protein is called the tiger protein. The tiger protein is almost coating a protein called a myocillin. So if the myocillin is a problem here. If the myocillin is going to be very high, it means it's going to cause glaucoma. As simple as that. I'll tell you why. The pathogenesis behind is that the myocillin is going to somewhat reduce the permeability of trabecular meshwork. So the permeability is lost. As we already know, so there's this iris, the cornea, and then the lens, the ciliary zonules, the suspensory ligament, which is catching up the lens. Like, okay, so this is approximately how we can draw it. Yeah. So the synthesis of the aqueous humor is going to be over here in the ciliary body, and then it enters the posterior chamber. It enters the pupil, and then it reaches the anterior chamber. It comes to the angle of the anterior chamber. Here is the trabecular meshwork, and it is somewhere like this. And just behind the trabecular meshwork is a canal. It's called the canal of Schlemm. Okay, it's called a canal of Schlemm. So after reaching the canal of Schlemm, what's gonna happen is that it's gonna enter the aqueous vein, and then from there it tends to enter into the vein called the episcleral vein. So basically this is the general systemic circulation that's gonna be entered. So yeah, the trabecular meshwork is like a filter. So if the filter is clogged, what happens is that the thing which is supposed to be drained, in this case is going to be the aqueous humor. The aqueous humor is not going to be drained properly. As a result of reduced drainage of the aqueous humor, there is going to be increased intraocular pressure. Well, while talking about juvenile glaucoma, I think one more point would be sufficient to complete it. So there's this very fancy group of medications called the steroids, used in a group of ocular conditions, including allergy and etc. So steroids will increase myocillin. Steroids are going to increase myocillin, which means steroids can indirectly increase intraocular pressure. So beware, do not forget to think twice before prescribing steroids to a glaucoma patient. Okay, so having completed the etiology and pathogenesis, let's go into the deeper aspects, like the clinical oriented things. So the clinical features includes two subheadings, the symptoms and the signs. Okay, so the symptoms are going to be 5 symptoms. So one with the eye, actually 2 with the eye, one with torchlight, and 2 with the torchlight, and 1 with just the cornea. Okay, so one is just the cornea. Okay, so let's get started. The eye is going to be increased in size because the pressure itself will make the eye bulging, because the cornea is a bit expansile thing. So that's what happens. And after that, what happens is that in the eye there is going to be tears. So the eye is going to be watery, and then the child is light sensitive, and it's also light irritable to such an extent that the child can go and hide his own head under the bed or a pillow and refuse to come out. And the third is for the cornea. The cornea is going to be a bit hazy. It's going to be hazy. So hazy cornea is otherwise called the frosted glass appearance. So those are the symptoms for glaucoma. And then we move on to the signs. So the signs include, for convenience sake, let's divide it into early signs and late signs. As we already would have guessed, the early signs will be very fast, or like very less, because in the initial stages it's going to be a bit mild. So the early stages, there is going to be this, I'm going to give you a mnemonic. It's go and pew. Okay, I don't know where pew came from, but that's a mnemonic. So yeah, G stands for ground glass appearance of the cornea, and this is opacities on the cornea. So basically these two things are for cornea. And P stands for photophobia, and W, most of you might have guessed it, there's going to be watering. So these are all the initial or the early signs. Then comes the late signs. Late signs are a lot of late signs are there. So the late signs include with, okay, I'm going to list out the signs based on the part of the eye is involved. So the first one is cornea. In the cornea, we will mainly focus on HAP striae. So HAP striae is nothing but discrete corneal opacities which look like lines of double contours, so somewhat like a railway track. And then cornea has this thing called the stromal edema, and as such cornea is going to be a bit enlarged as a result of increase in intraocular pressure pushing up the fibrous layer of the eye. And then we move on to the entire eyeball as such. The eyeball is going to be enlarged, again ditto. And then there comes the sclera, the white of the eye. The white of the eye is going to become a bit blue. I mean, yeah, I'll tell you why. Because of stretching of a fiber, it's going to lose its thickness, so it's going to become thin, and the underlying uveal pigment, especially over the ciliary region, it's going to be a bit more blue. And then comes the limbus. The limbus is stretched. And the cornea specifically is going to be a bit enlarged, and it might look like rata globus, but we might have to distinguish both of them. And then comes anterior chamber. Anterior chamber is going to be extremely deep, and then the lens is going to be a bit flat because the lens looks like this. It's going to be under a lot of pressure, so it's going to be a bit flat like this. And then comes the iris, the ciliary zonules. So the ciliary zonules are going to be a bit weak because of the pressure. So what happens is that the lens is going to tremble. So tremulousness of the lens. And the refraction problem could also occur. The main refraction problem we are talking about is myopia, again contributing due to increase in intraocular pressure. So we move on to the last part, that is the treatment. Treatment is going to be very simple. It's either medical or surgical. Well, it's going to be more simple when we have no medical treatment, which is advisable because medical treatment is not effective. Surgical treatment is better always. So we do this thing called goniotomy and trabeculotomy. So as a result of, okay, in goniotomy, we use this instrument called the, so that's a bit more, but then I'll just tell you, it's called the Barkin goniotomy knife. Using that, we basically open up the anterior chamber, because gonia meaning anterior chamber and tomy meaning cut. And then trabeculotomy meaning the trabecular meshwork is going to be cut. Well, for this, we use this instrument called the Ham's trabeculectomy probe. Okay, so that's it to sum up everything. But sometimes, okay, surgical is very effective, but however, the good prognostic factors include 2 months to 1 year of age of presentation. Bad prognosis meaning congenital at birth. So that's a bit bad prognosis. So otherwise, the surgery is going to be very good. So otherwise, trabeculotomy may be added with trabeculectomy in order to achieve big results. So that's going to be reserved only for severe cases. Well, if you enjoyed my video, click that like button because that keeps me motivated, and stay tuned. Bye.